Hi everybody, welcome to our module on acute pancreatitis. Acute pancreatitis is acute inflammation of the pancreas. This leads to liquefactive necrosis and hemorrhage of the pancreatic tissue. The classic symptoms are epigastric pain. It classically radiates to the back, and also nausea and vomiting. Now you may know that there are many different GI disorders that can cause belly pain, nausea, and vomiting, so it's hard to distinguish acute pancreatitis from other causes. And as we'll talk about later, there are pancreatic enzymes that are often checked in anyone who presents with these type of symptoms in order to rule out acute pancreatitis. There are many triggers for acute pancreatitis. We'll talk about all of them in this module, but the most common are gallstones and alcohol consumption. The physical exam is often not that helpful in acute pancreatitis. Patients usually have mild abdominal tenderness, but it's otherwise relatively nonspecific and doesn't really suggest any one particular diagnosis. There are two classic findings in acute pancreatitis that you should know as a medical student. The first one is called Cullen sign. This is hemorrhage under the skin near the umbilicus. It's shown in this picture here below the umbilicus. Often it actually spreads all the way around the umbilicus. The other physical exam finding is called Gray-Turner sign. This is hemorrhage under the skin in the area of the flank. And both of these result from the spread of necrosis and blood from the pancreas due to enzyme-induced damage. And you can see both of these findings in other abdominal processes. Both of them were first described in a ruptured ectopic pregnancy. The pathophysiology of acute pancreatitis involves the blocked flow of pancreatic enzymes while the synthesis of those enzymes is ongoing inside the pancreas. As a result, large amounts of trypsin get activated. I talk about trypsin in more detail in some of the GI physiology modules, but trypsin can activate more trypsin. It can also activate other pancreatic enzymes like phospholipase and chymotrypsin and elastase, and all of these activated enzymes begin to auto-digest the pancreas. In other words, the pancreas begins to consume itself. And this is one of the reasons acute pancreatitis is such a dangerous disorder, because once it gets started, it can start to become a self-perpetuating process and result in severe inflammation. Just to review the role of trypsin from our GI pharmacology module, trypsin is secreted as an inactive enzyme called trypsinogen, and normally when it reaches the small intestine there is a brush border enzyme called enterokinase which activates trypsin, and then trypsin activates all the other protein enzymes. So I've depicted this at the bottom of the screen. Enterokinase can convert trypsinogen into trypsin, and then trypsin can activate chymotrypsinogen to chymotrypsin. It can also activate elastase and carboxypeptidase. Trypsin can even go back and convert more trypsinogen into trypsin. So it's a very powerful pancreatic enzyme. And once it gets auto-activated, in other words, not activated due to enterokinase in the intestines, it can be very dangerous to the pancreatic tissue because all these enzymes get turned on and they begin to auto-digest the organ. As I told you before, the symptoms of acute pancreatitis can look like many other gastrointestinal disorders. There can be belly pain and nausea and vomiting, and you can see that in many other conditions, including some very common ones like viral gastroenteritis. So in order to make the diagnosis, it's important to check the serum levels of pancreatic enzymes in anyone with GI symptoms. And in patients who have acute pancreatitis as the cause of their belly pain, nausea, and vomiting, you will see increased levels of pancreatic amylase and lipase. Now, unfortunately, both of these are elevated in conditions other than pancreatitis, but lipase is more specific for pancreatic damage. And importantly, in severe acute pancreatitis, the levels will be very high, and that will help you distinguish it from other causes. You may also see abnormalities of the liver function tests, especially if gallstones are the cause. When gallstones obstruct the flow of pancreatic enzymes into the duodenum, you can see a cholestatic picture of abnormal liver function tests. I talk about cholestasis in the bile modules, but in patients who have something obstructing the flow of bile, they will have an increase in the ALK phos level that is much greater than the rise in AST and ALT levels. You can also see a rise in conjugated bilirubin. All of these things will occur if gallstones are the cause of acute pancreatitis. And then finally, you can see an elevated white blood cell count in patients who have acute pancreatitis. Imaging is also sometimes used when the diagnosis of acute pancreatitis is being considered. An ultrasound of the right upper quadrant may show evidence of gallstones in the bile ducts. A CAT scan may show edema of the pancreas and necrosis. We'll see some pictures of that in a minute. A CAT scan can also sometimes show bile duct stones and bile duct dilatation. This is a CAT scan of a patient with acute pancreatitis. This is the pancreas in the middle of the screen here. You can see that the edges of the pancreas are dark. Look at this dark portion here surrounding the pancreas, and that is edema from acute pancreatitis. Everything I mentioned up to this point are potential abnormalities you can see on lab testing or imaging, but technically to make the diagnosis of acute pancreatitis, there are three criteria. The first one is epigastric pain. The second is an increased level of serum amylase or lipase greater than 3 times the upper limit of normal. The higher the amylase and lipase, the more likely they represent pancreatitis and not some other source of those two enzymes. And then the third criteria is abnormal imaging of the pancreas by CAT scan or MRI. And you need at least 2 out of these 3 criteria. So for example, if a patient has epigastric pain and markedly increased amylase and lipase, then you can make the diagnosis of pancreatitis and you don't need to do any additional imaging. The 2 most common causes of acute pancreatitis, as I said before, are gallstones and alcohol consumption. So let's talk about gallstones first. So if we look at this picture of the stomach and the duodenum of the pancreas, if a gallstone lodges itself here in the common bile duct, it will not only obstruct the flow of bile, it will also obstruct the flow of pancreatic enzymes into the duodenum. This can trigger a bout of acute pancreatitis. And as I told you before, in addition to seeing signs and symptoms of acute pancreatitis, there will be abnormal liver function tests indicating that there is obstruction to bile flow. And when you do abdominal imaging in patients who have gallstones causing acute pancreatitis, you will see dilated bile ducts. The stone obstructs the flow of bile and the bile ducts become enlarged, and you can see this on imaging studies. Alcohol consumption is the other common trigger of acute pancreatitis. The exact mechanism is unclear. When alcohol is the cause of acute pancreatitis, it's usually clear from history. This will usually be a patient who is a heavy drinker and has just consumed lots of alcohol. It often occurs in alcoholics. For reasons that are not entirely clear, alcohol can sometimes trigger the release of pancreatic enzymes, and then you can get trypsin activating all the other enzymes as we discussed before. Acute pancreatitis is relatively common, and you will most likely encounter it on your clinical rotations, and most of the cases you will see will be due to gallstones or alcohol consumption. There are, however, a number of other causes of acute pancreatitis that you need to know about, especially for step 1 of your boards. So first of all, acute pancreatitis can be idiopathic, meaning there is no identifiable cause. And then all of these triggers listed on the screen here can potentially cause acute pancreatitis, and you need to know about them for step 1. So we'll go through them one at a time in the next few slides. Blunt or penetrating trauma can potentially damage the pancreas and cause acute pancreatitis. This is uncommon, but it can occur. One of the places where it sometimes occurs is in children who are restrained by seatbelts. The seatbelt can jar the abdomen and lead to trauma of the pancreas. In general, though, trauma causing acute pancreatitis is rare, and that's because, as you know, the pancreas is in the retroperitoneum, and therefore it's hard for trauma to the front of the body to damage this structure in the back of the body. Infection is a rare cause of pancreatitis. It's more commonly due to viral infections, although it can occur in the setting of bacterial or parasitic infections. One of the classic causes is mumps. I talk about mumps in the infectious disease modules. It causes inflammation of the parotid gland, as is shown in this child here, but it can also lead to acute pancreatitis. There are a number of drugs that have been reported to cause acute pancreatitis in a small number of patients, and reviewing the medication list is an important part of the workup of any patient who presents with acute pancreatitis without an obvious cause. Some of the drugs that may trigger pancreatitis that are worth knowing for step 1 include the GLP-1 agonist. These are drugs that are used to treat diabetes. These are drugs like azenitide and liraglutide. In both of these drugs, after they were FDA approved, there were post-marketing reports of acute pancreatitis in a small number of patients. Sulfa drugs can sometimes trigger acute pancreatitis. And then finally, 6-mercaptopurine is a chemotherapy drug. It's also sometimes used as an immunosuppressant, and it can trigger acute pancreatitis. Toxins are a well-described cause of acute pancreatitis. In particular, the venom of some arachnids and reptiles are known to trigger acute pancreatitis. The brown recluse spider is a classic cause. At the bottom left side of the screen is a picture of a brown recluse spider. Some scorpions have venom that can trigger acute pancreatitis. There's a picture of a scorpion here to remind you of that. And then there is a reptile called the Gila monster lizard. This is a picture of it on the screen, and it has a venom which can also be toxic and cause acute pancreatitis. Autoimmune pancreatitis is a very rare condition that causes chronic abdominal pain. Patients with autoimmune pancreatitis have recurrent attacks of acute pancreatitis and a diffusely enlarged pancreas seen on imaging. This is a very rare condition. The thing you need to know about it for step 1 of the boards is that it involves IgG4 plasma cells. These are a marker for the disease. You can identify them in the pancreas, and serum IgG4 levels will be elevated in patients with autoimmune pancreatitis. And it responds to treatment with steroids, which is consistent with the fact that it's an autoimmune disease. Hypercalcemia of any cause can rarely trigger a bout of acute pancreatitis. This is believed to occur because calcium can deposit in pancreatic ducts, and this may activate trypsinogen and convert it into trypsin. And as we saw before, once trypsin is activated, it can activate the other pancreatic enzymes and lead to autodigestion of pancreatic tissue. Hypertriglyceridemia is a well-described cause of acute pancreatitis. A normal triglyceride level is about 100 to 200. If the level gets over 1,000, this can cause acute pancreatitis. In fact, one of the main reasons we treat high triglyceride levels is to prevent pancreatic injury. The exact mechanism is unclear, but it's thought to involve chylomicrons, which you may know are large lipid particles that carry triglycerides. Normally they're formed after meals and then they clear a few hours later. However, they are always present in the plasma when the triglyceride level gets over 1,000. This may obstruct capillaries and lead to ischemia, and the vessel damage can expose triglycerides to pancreatic lipases. The triglycerides can then be broken down, and this can lead to the formation of free fatty acids in the pancreas. The acid can lead to tissue injury, and that can trigger pancreatitis. And this is believed to be the mechanism of acute pancreatitis and hypertriglyceridemia. ERCP stands for endoscopic retrograde cholangiopancreatography. It is a method of imaging the biliary tree and the bile ducts. It uses a combination of endoscopy and fluoroscopy. So the procedure begins by taking an endoscope, which is a long tube with a camera at the end. That scope is inserted all the way through the stomach and into the duodenum. It then has an instrument at its tip that can be inserted into the bile ducts. You can then inject contrast material, which the fluoroscope can take a picture of, and this will show you the biliary tree. And this is important for imaging and also sometimes therapy of biliary disorders. The endoscope can be used to treat strictures and remove gallstones and treat other causes of biliary disease. Shown on the screen is a cholangiogram obtained via ERCP. So the endoscope is injecting dye into the biliary tree, and then a fluoroscope takes a picture, and you can see the biliary tree filling with black contrast material. And the reason I'm talking about ERCP in the pancreatitis module is because one of the complications of ERCP is pancreatitis. If you irritate the pancreatic duct, that can lead to obstruction of flow of pancreatic enzymes, and post-ERCP pancreatitis is a well-described phenomenon. Duodenal ulcers are another potential but rare cause of acute pancreatitis. The pancreas sits just behind the posterior duodenum, so if one of those ulcers ruptures, this can lead to acute pancreatitis. And this is an endoscopy image of a duodenal ulcer here. You can see this breakdown in the lining of the GI tract shown on the screen. The treatment of acute pancreatitis is something you will come to know well on your clinical rotations. It generally involves three things: NPO status, IV fluids, and pain control. NPO means nil per os. This means the patient should not consume food or liquid, and this helps to rest the pancreas because it prevents stimulation from gastric contents. IV fluids are administered because there is significant fluid loss due to pancreatic edema. In addition, the inflammation leads to diffuse vascular leak, so you have to administer IV fluids in order to maintain the blood pressure and the renal perfusion, especially in the setting of NPO, which means the patient won't be consuming any liquids. Pain control is important. As I said before, epigastric pain is a major feature of acute pancreatitis. And if you do these three things, most of the patients you admit to the hospital with acute pancreatitis will get better in about 2 to 3 days. Patients with more severe acute pancreatitis can develop a clinical syndrome known as SIRS. SIRS stands for the Systemic Inflammatory Response Syndrome, and it is a clinical syndrome of dysregulated inflammation. And asking medical students for the 4 criteria of SIRS is a classic question on rounds, so you should be familiar with the diagnostic criteria of SIRS. So in order to have SIRS, first, you have to have either an elevated temperature above 38.3 Celsius or a low temperature below 36. The heart rate must be above 90, the respiratory rate must be above 20, and the white blood cell count must be increased above 12,000. If you have these criteria present, then the patient has SIRS, and SIRS can result secondary to many different causes. You can see it among trauma patients. You can see it in more severe acute pancreatitis. If you have SIRS plus an infection, then you have sepsis. And you should know, in regards to our module today, that SIRS in pancreatitis indicates a patient with more severe disease. When you admit patients to the hospital for acute pancreatitis, you often monitor for development of these criteria. If you see them, it means the patient is beginning to get sicker. Because patients with acute pancreatitis can initially look well and then rapidly deteriorate, a number of criteria have been created to try and identify features which predict that a patient with acute pancreatitis is likely to become very ill. One of the classic criteria is called Ranson's criteria. There are a number of clinical features which, if present either at admission or at 48 hours after admission, predict a worse prognosis. And I've shown all of them on this slide here. You don't need to memorize these, but these will come up in your critical care rotations in 3rd year when you take care of patients with acute pancreatitis. And basically a point is given for each criteria that's present, and mortality goes up among patients who have more points and have a higher score. And besides Ranson's criteria, there are other criteria that are used. Apache 2 is one of the newer ones, but all of these do the same thing. They attempt to predict features present at admission or shortly after admission that indicate a patient is likely to become very ill. So like I told you before, many patients with acute pancreatitis have mild disease, they have few of the Ranson's criteria present, and they're admitted to the hospital for a couple of days and then they improve. However, there are some patients with severe acute pancreatitis and it can be a life-threatening disorder. So now what I'm going to do is walk you through the different complications that can occur, and everything I've listed on the screen here is a potential complication of acute pancreatitis. DIC stands for disseminated intravascular coagulation, and the name tells you everything you need to know about this disorder. It's disseminated, so it occurs diffusely throughout the body. It's an intravascular process that occurs inside of blood vessels, and it involves activation of coagulation factors. Essentially in DIC, there is a diffuse activation of clotting factors. It's sometimes called a consumption coagulopathy. There is so much clotting going on that all the clotting factors are consumed. This results in prolongation of the PT and PTT. Essentially, you run out of clotting factors from all the clotting occurring throughout the body. All those blood clots will use up all the platelets and the serum platelet level will get low. And then finally, the blood clots will lead to vascular occlusion. This develops into a microangiopathic hemolytic anemia where the hematocrit becomes low and there's evidence of ischemic tissue damage. And this often presents as bleeding. So a patient who has acute pancreatitis and then develops diffuse bleeding and an elevated PT-PTT and a low platelet count has probably developed DIC. ARDS is a much feared complication of acute pancreatitis. ARDS is the acute respiratory distress syndrome. It presents as respiratory failure with hypoxemia. It's caused by damage to the capillary endothelium and the alveolar endothelium. Protein escapes from the vascular space and fluid pours into the interstitium. I discuss ARDS in more detail in some of the pulmonary modules. This is an X-ray of a patient with ARDS. You can see white, fluffy infiltrates in both lung fields. And you should note that pulmonary edema from heart failure or any other cause can look just like this. What's different about ARDS is that the pulmonary capillary wedge pressure is normal, indicating that this fluid leaking is not due to high pressures in the heart, but it's due to a leaky vascular endothelium. And many patients who have acute pancreatitis end up ventilated in the intensive care unit because of development of ARDS. Sometimes pneumonia will develop on top of this, and the result can be a life-threatening scenario for patients with acute pancreatitis. A pancreatic pseudocyst is a walled-off collection of edema and fluid, and importantly, pseudocysts contain minimal or no necrotic pancreatic cells. I make this distinction because there is another entity called walled-off pancreatic necrosis, and that is similar to a pseudocyst, but instead of containing edema and fluid, it contains necrotic cells. In a pseudocyst, the structure contains almost entirely edema and fluid. These are called pseudocysts because they lack an epithelium. What is surrounding the edema and fluid is a collection of granulation and fibrous tissue. These usually develop outside the pancreas, and they take 4 weeks to grow and mature. In other words, it takes 4 weeks for all this granulation and fibrous tissue to surround edema and fluid and create the pseudocyst. So in a board question, a pseudocyst is not going to be diagnosed in someone who just developed acute pancreatitis. It's going to be in someone who has had acute pancreatitis for several weeks. Maybe they're still in the hospital or maybe they're coming for follow-up. They're usually diagnosed by imaging, usually CAT scan or MRI, and they are often asymptomatic, so it's simply the routine imaging that picks up the presence of a pseudocyst. And although they often occur in patients with acute pancreatitis, they can also occur in patients with chronic pancreatitis. About 10% of patients with chronic pancreatitis develop a pancreatic pseudocyst. The most common location for a pseudocyst is in the lesser sac of the abdomen. I talk about the lesser sac in the GI anatomy modules. It is a space in the abdomen found behind the stomach and in front of the pancreas. So obviously, if it's located in front of the pancreas, it's a natural location for a pseudocyst to develop. This is a picture of an enormous pseudocyst here pushing its way into the lesser sac from the pancreas sitting behind the stomach. Most pseudocysts resolve without intervention. Sometimes, if they're very large, they require drainage. The feared outcome of a large pseudocyst is rupture. This will lead to inflammation throughout the abdomen, which is called peritonitis and can be life-threatening. Sometimes pseudocysts lead to the development of fistulas between structures inside the abdomen or obstruction of the bowel. And they can also sometimes become infected, and when they're infected, you develop a pancreatic abscess. So let's talk about pancreatic abscesses now. This is an infection of a pancreatic pseudocyst, and this usually occurs late, about 10 days into a bout of acute pancreatitis, and it's usually caused by intestinal bacteria that find their way into the pseudocyst. E. coli is a common culprit, sometimes Pseudomonas or Klebsiella or Enterococcus, and this presents as a patient with fever and failure to improve clinically about 10 to 14 days into a bout of acute pancreatitis. Fat necrosis is when the inflammation of acute pancreatitis progresses to involve the fat that surrounds the pancreas. And the most important thing to know about this, especially for step 1, is that fat necrosis can lead to low calcium and low magnesium levels in the serum. The way this happens is that pancreatic enzymes like pancreatic lipase release free fatty acids in the fat that's surrounding the pancreas. These fatty acids then bind electrolytes like calcium and magnesium and pull them out of the serum. This is a process called saponification. And low calcium, as we saw before with some of the scores for acute pancreatitis, is a poor prognostic indicator, and that's because it suggests that the pancreatic inflammation is so extensive that it is now involving the fat surrounding the pancreas. Just to help you understand the saponification process that leads to low calcium and magnesium, let's look at what happens to triglycerides in the fat around the pancreas. This is the structure of a triglyceride shown on the screen. It contains 3 fatty acids bound to a glycerol molecule. When those fatty acids are released, they can bind to calcium. The calcium can bind to the carboxylic acid end of the free fatty acid. This creates a calcium soap and it pulls calcium out of the serum. And then finally, you should know that acute pancreatitis can progress to multi-organ failure and death. Severe pancreatitis, as we have seen, can lead to DIC and ARDS. We saw how it can lead to infection, and this can lead to septic shock. Life-supported treatment is often required in the ICU when you do critical care rotations. Some of your patients will probably have acute pancreatitis. They require mechanical ventilation, sometimes vasopressors, and sometimes dialysis if the shock leads to kidney shutdown. And this can progress to multi-system failure and death. These patients can have persistent hypotension despite the vasopressors. Sometimes you're unable to wean them from the ventilator. Sometimes the renal failure requires dialysis. And all these things, if they continue to progress, can potentially lead to death. And that concludes our module on acute pancreatitis.